So before I turn it over to Zach to introduce our esteemed panelists, again, thank you for participating today. We look forward to your continued engagement and guidance regarding your needs, wants, goals, and wishes for the future. We are here to help you be as successful as possible, and it is our privilege and pleasure to support you. Zach, ACVP's Director of Education, can you please kick us off, providing us with any housekeeping information we may need, and then introducing the panelists?
Yes.
Thanks.
So just a quick reminder to the panelists, if there is ambient noise in your background, if you could just mute yourself while other panelists are talking, then unmute when you're planning to speak, that would be great. And when you do unmute, just give yourself 1 or 2 seconds, just a quick beat, because there is sometimes a lag between when you turn your microphone back on and when we'll actually be able to hear you. And to everyone that's watching the stream right now, if you do have questions, please feel free to put those into the chat function on YouTube. Either myself or Kurt Jensen, our communications director, will be monitoring that chat, and we will be happy to pose some of your questions to the panelists as you send them in. All right. So just a quick introduction to today's panel that talks about what we're going to be discussing today. With this panel discussion, we'll be exploring what a post-COVID-19 world might look like. And while we don't expect any of our panelists to have a crystal ball at their disposal to give us a perfectly clear view of the future, you send them in. All right. Sorry, 1 second.
Sorry.
Thank you. While we don't expect anyone to have a crystal ball, we know that over the past few months, each of us has had experiences which have shaped our perspectives of healthcare, technology, of virtual health modalities, of organizations, our communities, and the overarching principles that guide our work. No doubt, at least some of the
And from an overall virtual visit, yeah, great question, Dave. We went the peak of our of COVID here within the Boston area. We probably had about 95% of all our physicians were doing telehealth. Yeah. So from a telehealth visit, the few and far between that were not were the new patients that had to be seen that just couldn't wait. Yeah. But now we're down to about 50% actually. Now that we're kind of at the base of the curve. Yeah. And we've had pluses and minuses that we've experienced.
Sorry, I don't mean to cut you off, but since we are in that hour block of time, we're going to jump back in because I believe that the internet is back. So I'll ask the question much more quickly than I did the first time. Dr. Bilazarian, could you please tell us about your experience and Abiobed's experience with virtual health modalities and how you anticipate expanding on the use of these virtual health tools in the months to come after COVID-19?
Great, thank you. So I'm Seth Bilazarian, Abiomed's Vice President of Medical Education and Training, and we're makers of the Impella platform of devices. We're based in Massachusetts, north of Boston. And our company has been investing for a number of years in these strategies. We have a technology called Impella Connect, which is a cloud-based platform which streams unidirectionally from the console to the cloud that permits visualization of the Impella data on a mobile device, a phone, and we make it available to healthcare practitioners at the hospital. They can only see their own hospital data, but our field support team can see the hospitals that they support. So our Boston area clinical team can see all of the Boston area hospitals that are on Impella Connect. What that's provided for us is the opportunity to more quickly resolve alarms, support patients. But in COVID-19, we found that many nurses were using it in the ICU for patients that have shock and are being treated with Impella, to be able to not even have to go into the room to visualize alarms, to get support, and to not have to use other methods like FaceTime or other kinds of strategies that were used previously to try to connect and make a virtual connection. We now have this data streaming, which has been a huge benefit. This is the first step in the strategy of structured data and supportive technologies for informing clinicians on how best to help patients. We have artificial intelligence platforms in development, which will give predictive analytics for where patients' blood pressures are trending and other kinds of important data like left ventricular systolic pressure and cardiac output, which we will be rolling out in the next 18 to 24 months to centers that will all be screened and be very valuable, we think. And it's COVID-19 has really accelerated what we already had in development. So thanks for the question.
Sorry, I was muted, so I had to unmute myself. Thank you for your answer. Monica, Floyd Barrett, if you could please answer the same question, how you guys have been using virtual health modalities at University of Florida Shands Hospital. And if you could also just briefly introduce yourself and your role again, that would be great.
Okay, great. I am, my name is Monica Barrett, and I am the Divisional Director of Cardiovascular Services at UF Health, University of Florida Health in Jacksonville, Florida. So prior to this pandemic, we had not been on the telemedicine bandwagon. So we had to learn quickly. We had to get things up and running pretty fast. And I think we did a good job in doing that. The way that we do telemedicine here is the patient has something called MyChart, which is their ability to log on and see their appointments, their lab results, pretty much it's their communication into our EMR. So the difficult part was teaching the patient how to do this, how to go into MyChart and then go into Zoom. So that was the most difficult part of this, was getting the patients on board. It was great for the ones who had already been doing this with their PCP. So once we asked them to do this for their cardiology appointment, it was easy. But for those who had never done it, it was a bit challenging. We actually tried it first until we could get everybody up and going. Another big challenge we had was cameras. Not everybody had cameras, and then all of a sudden the whole country, the whole world was sold out of cameras. So we've done a lot of sharing of cameras. People will run in here and grab my camera and take it to go do their virtual visits. So that was an issue as well. But one of the things that we're going to do moving forward is for some of our outlying areas, PCP offices that are not so close to the hospital, to our downtown or north location, is we're going to offer them virtual visits for their patients in their office. So instead of the patient having to come drive downtown for their visit, they can actually go to the PCP's office, and we're setting up blocks of time where during that time period, all the patients at that PCP or surrounding PCPs in that area, all the patients they wanted to refer to cardiology or CT surgery, we will do the telemedicine visit in their office. They will come in, the medical assistant in that office will do the vital signs, get an EKG, do med reconciliation, and then set the patient up in a little workstation where we can do the virtual visit with the patient. So that's going to start. We've done it at one location and it's worked really well. So we're going to roll that out to other locations probably in the next few weeks. So we want to stay on the virtual visit route, but do it in a little bit different way. I don't know what everybody else has experienced, but having a virtual visit with a cardiologist or a cardiology provider is a bit difficult. You have to ask the patient, as you know, when's the last time you had your blood pressure? What was your blood pressure? And it can be a little confusing at times. So actually having them have all their vital signs done in a PCP office and have that EKG done and have someone to help them get set up is going to be, I think, a huge benefit for us.
Absolutely. And I can understand why the patient learning, in addition to the practitioner learning, would be an especially difficult obstacle to try and get over, because as you're learning something and then having to teach it to another group of people, that can sometimes be difficult. But on the other hand, it's also a really good way to make sure that learning is retained.
Right. And you have to remember that most cardiology patients are older. And so them being able to work with their phone or their computer to understand how to do virtual visits has been, a bit difficult for them. And the other thing that we ran into is a lot of patients would tell us, well, I usually have my son or my daughter or my niece or my nephew or whoever come over and help me with these things. But during the isolation, when they can't have visitors or people come over, they were really locked down. And so we then resorted to telephone visits where it was just the cardiologist speaking via telephone to the patient. And if that's all that we could do, that actually was better than nothing.
That makes sense. All right, Russ, I'm going to throw the same question to you. How have you guys at Loma Linda been handling your virtual health changes that have been brought about by the pandemic?
Well, the challenge for us was largely due to some of the, I would call it, antiquated IT policies, but we revamped those relatively quickly. The clinic staff became what I would call ad hoc IT experts in calling patients and setting them up, making sure that the physicians had what they needed to perform a televisit or a telephone visit. And many of my physicians now actually prefer the modality, as that they can have a cleaner clinic day has been some of the input or feedback that I've heard back from the physicians. And uniquely, even with the challenges of having some of the knowledge gap in technology with some of the older population, our patients have been extremely happy with it. The feedback we've been getting from them has been great because of the fear of coming into a hospital or traveling across the town to come to an appointment. And secondarily, to expand on Dr. Bilzerian's point, we are in the process now of implementing the Impella Connect and working through those things so that our clinicians can gain more real-time access without entering rooms or even coming into the facility in the middle of the night on some of these patients. So overall, our satellite clinics are adopting a similar strategy that Monica had described. And we continue to work through the barriers with those with some relatively good success. I mean, there's been challenges across the board, but overall, the feedback has been positive. While some physicians are now resorting back to in-office visits, many of the physicians have declared that they're going to remain as much as 75% virtual visits.
All right. Something you said actually about creating a de facto IT department out of the, did you say it was the clinicians? I'm sorry.
Yeah, so the MAs in the front of the house for the clinic largely ended up becoming kind of IT support for patients and walking them through the steps. And it took us a bit to iron out kind of a flow chart of check this and check that and make sure that this is turned on for patients. But once we got it ironed out, there were a couple of shining stars who kind of became, like I said, de facto IT support for a virtual visit.
See, I find that really interesting because right now we've seen a lot of like clinical roles being expanded. It's kind of not contrary to specialization, but it's a different kind of specialization where they've been trained in one thing and now they need to take on these different roles and pass them on to either patients or coworkers. And so this next question is for John and Dave. How have you seen that kind of hybridity at your institutions? People taking on new versatile roles that kind of expand upon what they were trained to do or what they did initially. And do you think that any of that expectation that you are able to jump into multiple roles will be carried with us after COVID-19? Or do you think that we'll return to more of a kind of, specialized, this is what I do, this is what's in my scope of practice, and that's it kind of mentality? And I'll go to John and then Dave.
Oh, okay, great. Thank you. Yes, and thank you, Zach. Yeah, John Gardner here, Senior Administrator for Cardiovascular Medicine at as part of Steward Health here. And Steward Health is a 11-state, approximately 40 hospitals, fully 100% physician-owned private entity. I'm the senior director here, primarily at St. Elizabeth in Boston. Also have other responsibilities throughout the health system under George Ambruski, who's our senior VP and our chief of cardiology as well. So just to answer your question, Zach, yeah, and follow up with Russ, there's no question about it. Diversification of those skills actually was a critical component of our success through the whole COVID uptick, peak, and now we're in the midst of going down in the curve here within the Boston, the Massachusetts region. As you know, unlike some other states within the U.S., like what we're hearing in California and Texas and Utah and Arizona and Florida, where it sounds like they're experiencing what we experienced here back March through May. So So many were working in areas that they had not been trained, that subspecialty. So for example, our cardiologists, our subspecial cardiologists in particular, took on roles within as intensivists, as pulmonologists, wherever the need so determined. So it was I guess the best mentality, a battle cry for, we're in this together, we're going to survive together, so we need to do what we need to do together, and do it the right way for the patient and for the community. Now, question being, will this continue? That's a good one. I think it's a great question. We definitely learned from my experience, physicians, staff, administration, learned many skills that we did not have before and needed to, and relied on many to get the job done, to care for those patients, to ensure that we were doing it the right way and doing it best for our community. But I think the time will tell. So since we've already experiencing now, and we were reopening relatively slowly, appropriately, very safely, many of the specialized skills are at the pinnacle, are primarily what we need to do, and that's kind of come back, if that makes sense. So with the priority of doing what we've been trained for originally, like say electrophysiologist, interventional cardiologist, whatever it may be, a CT surgeon. So that's at the top of mind. But with the uncertainty of knowing what is kind of next wave, when, how, if, I think we are definitely better prepared if we need to do that.
It's not surprising. I mean, obviously these clinicians are smart people, but definitely necessity is not only a mother of invention, but it's really easy to pick up skills when they're required to save lives or keep an organization afloat. So
yes, for sure.
Dave, same question to you. How have you seen that hybridity and versatility within your organization?
Yeah, thanks, Zach, and good morning, everyone. I'm Dave Strelo from St. Luke's Mid-America Heart Institute here in Kansas City, St. Luke's Health System. My role has recently transitioned to more of a business director role for cardiology. But through the pandemic, it's been really interesting to just watch how our organization has adjusted. In the cardiology perspective, the specialty areas of cath, EP, CV surgery, although those teams were prepared to be transitioned to an area of need, it really never really came to fruition. And today, we are bringing in all of those cases that were deferred. So the team is very, very busy, working longer hours and generating the revenues that are needed for hospitals to recover. But from a virtual visit standpoint, we did see, and I would echo the comments of Russ and Monica. If your organization was prepared in advance, and I think ours did fairly well, a virtual visit can go quite easily. But there are some components. Monica mentioned my chart, and I have some personal experience with a virtual visit, and the medical technologist became the IT expert to talk us through it as our family got on the computer. But my chart was very helpful, but it's dependent upon your organization having a shared EMR, EHR system available to both the ambulatory and inpatient providers. And so most of us on this call, as moderators here, are in organizations like that, but in your own organization, it may be different and more difficult. I think one of the areas that we likely missed pre-pandemic was in the Epic system. In our EHR, there is a checkbox, has the patient enrolled in my chart? And we ask the question, but we don't encourage the enrollment. And I think moving forward, telehealth, I think, will be a new role in healthcare systems. I think CMS has given us opportunities to improve efficiencies through telehealth and virtual visits, and I think everyone's going to get on board with that. And I think there's going to be new telehealth support persons coming from the clinical provider side of this, and it'll be a brand new role moving forward as telehealth, as we take advantage of the benefits of telehealth.
Absolutely. I would be interested to see. Oh yeah, go ahead, John.
Yeah, 100% agree here. I think superb comments by everyone, and similarly, what we've experienced here, and I think one physician said it very well, is that the change here has been the need for adaptability and flexibility, and this is going to be with us for a long time. And as many know, even the CMS administrator Seema Verma had mentioned, I think she phrased it as the genie's out of the bottle, and we're not going back. So the obvious from a revenue and reimbursement standpoint, as David mentioned, obviously that's going to be key. But we also see areas pre-COVID that we were identifying, at least in the Massachusetts markets, that were underserved, and we did not have the clinicians to do it. And unfortunately, at the time in the state of Massachusetts, we did not have the reimbursement either. So we see a great benefit here in a lot of other ways on how we can apply this moving forward, not only from a skill standpoint, technology, and then the reimbursement and satisfaction and access to patients we did not have before.
Yeah, Dave, go ahead.
And one other comment in regards to Dr. Bilzerian. We are physicians for training would often go to other sites with new technologies and do on-site observation for clinical training of a physician. And that is now being discouraged. And so we're currently working with another teaching to physicians webinar similar to this. And the major organizations, TCT, ACC, are now doing virtual conferences also. So it'd be interesting to hear from Dr. Bilzerian, you know, how his company is also training new providers in this technology.
Dr. Bilzerian, do you want to go ahead and answer that?
Yeah, thanks for that. I love that question. I really appreciate it. It's a softball question because it's something we're highly invested in, and I'd love to talk with you more about what you're doing to make sure that we're aligned. We have begun that. Yesterday, we had our first live case transmitted here for our own team's education on a protected PCI, that case from York, Pennsylvania. I'm unfortunately missing the beginning because I committed to you all a second case that's coming right now from Oshner Medical Center in New Orleans, again here. So we're demoing a variety of technical platforms for exactly as you described, our strategy of educating physicians and ultimately others on the healthcare team on educating on how best to use our device. We think there's two different approaches, just a little bit more detail. There are some centers, as you know, that have for a long time transmitted live cases. We've seen them all at courses. And those are larger academic medical centers that have fixed infrastructure for transmission. So those are already in place and we can easily do that. That was the case yesterday from York, Pennsylvania. But other smaller centers that equally need training that don't have the infrastructure, we're exploring a variety of new technologies that are often headwear that a physician can wear that will actually see what the physician is seeing, whether it's the angiogram, the hemodynamics, the patient's groin, and a proctor can be in that physician's ear for training. So we're looking at both of those, and we expect to have a variety of those online beginning next month in our new platform, educational platform called CAMP, which stands for Coronary Artery and Myocardial Protected PCI, and that's a website for Impella users that will be in a rich community for this kind of education. But I'm eager to learn more about what you're doing, and we can maybe...
Most robust information sharing is with our sister facility down in Marietta, and that's a real-time sharing through our Patient Safety and Reliability Committee. Updated statistics, supplies, PPE, you name it. That's a real-time dashboard that exists for all administrators to access, as well as it's a two-way communication through a command center that still exists in terms of need or in terms of resources. So making sure that we have the right amount of people shifting to one area versus another. And so far, we haven't had to utilize that a lot. It's been more on the PPE side that we've had to do that. Secondarily, we work real closely in that our physicians work in tandem with the Riverside University Medical Center. And that information sharing has been both virtual via email, phone conversations, and an active briefing process that we have twice a week on Tuesday and Thursdays over the lunch hour for the physicians to get together to share challenges, resources, victories, anything that they've come across. And as the initial upstart of that was, there was a lot of information that was being shared, and now it's more becoming kind of almost a case conference at times of how would we approach this, or how are you guys using your testing resources for said procedures along those lines.
Thank you. Monica, how about you? How has information been being shared between your institution and others and within your institution?
Well, I don't really think there's been much information sharing between other institutions. We have our sister hospital is in Gainesville, the University of Florida, Shands UF Health, Gainesville. So we talk with them, but I will tell you, it has been a little bit difficult through this pandemic to obtain information. And I'll give you an example. So when we were deciding what to do as far as stress testing, and should we stop stress testing? Should we limit stress testing? Should we only do pharmacological stress testing? We were trying to see what everybody else is doing. What's been the standard in the community? What's been the standard anywhere? So it was very difficult for us to Google and find out what, say, like the American Heart, the ACC, what they were recommending. There was really no definites out there. It was pretty much there was no definite recommendation. So then we started calling all of our hospitals here in the community, and asking what they are doing. But I will say that part has been difficult. I don't feel like that, at least here in this area, that we have shared enough. And I'm just talking just cardiology wise. I feel like institution global wise, our CEO has been in contact with all the other hospital CEOs, and I know they have a weekly Zoom conference where they're discussing what's going on. What's going on in your hospitals? What are we seeing here? There's a lot of that going on right now because August 24th, the Republican National Convention is coming here to Jacksonville, and we're all concerned. And so as hospitals, healthcare providers, we're trying to join together to see what our plan's going to be as to how we handle that if we have a big spike in our number of COVID cases. So in that sense, there has been a lot of Zoom meetings with other hospital officials. But I would just say, cardiology wise, I've been disappointed that we haven't had more support as a group in our community and with our national organizations. I don't know. What is everybody else? Maybe it's just me. Maybe I haven't been able to find. I've really been looking for guidelines on what should we do? How should we handle this? Should we be testing our echo patients?
Yeah, John.
Yeah, sure. Great point, Monica. And similarly, here within Steward Health, we ran into some kind of a same hurdle, not unlike what you're seeing there. And we had some things were in place within the health system that was helpful, and something that George Ambruski, the senior VP for the health system, had in place when I joined here about a year ago. So that was one, and that was specific to primarily cardiovascular medicines. We have a monthly meeting where everyone gets together and kind of share best practices, present problems, and with the intent for solutions. But also, we had a similar scenario with our cardiac rehab. So do we keep it open? Do we close it? Do we minimize it?
Yeah.
And we relied on some of the local hospitals. We made calls. There was actually some visits, and the professional organization did help with some of that guidance, along with at a high level, using the CDC and the NIH and some other more government centered to help us make our decision. We did decide, at least in cardiac rehab, with very strict guidelines to stay open. And some of that was based on our professional society, the guidelines within our state, which were not necessarily fully aligned with what the national guidelines were. But we were 29% of the nation that stayed open through the whole COVID crisis. None of our patients and none of our staff ever tested positive.
Well, oh yeah, go ahead.
I'll tag onto what Monica said. I too had the same frustrations looking for guidance from the societies or from other professional organizations of exactly how to proceed. And cardiac rehab and the diagnostic testing was probably two of the highest areas where we had concerns about potential transmission, risk to patients, risk to providers. So it was largely, we were kind of shooting in the dark, and we based it basically solely on testing guidelines and screening of patients. So yeah, there was very little guidance from the professional organizations of how to proceed in this situation.
Interesting. Dr. Bilazarian, I'm going to turn the same question to you, but I'd like to qualify it a little bit, because I know that on the supply side, there might be different kinds of concerns about things that are proprietary, like intellectual ownership over ideas and products. So I'm wondering in what ways you guys are sharing information with hospitals, but also if there's been any, industry to industry communications going on about how do you train and et cetera.
Yeah, I regret that we didn't have this call earlier, because I could have helped with some of the concerns that came up, because we've been running an almost weekly call on COVID-19 every Friday at 4 p.m. We reduced it to every other, because the pace of new literature and guidance was coming so fast that our customers had shared with us that they were trying to take care of patients and didn't have the bandwidth to keep up. So we created this forum that we recorded, and we have them all recorded for those who are interested. We have 19 medical offices globally. I assigned each one a different topic, whether it was cardiovascular complications related to myocarditis, cath lab issues, ventilator issues, PPE, antibody testing, a variety of topics. And those were presented each week on Friday at 4 o'clock. And it was very well received. We invited 700 customers from around the world and recorded it and had lots of good feedback. And we got the information not only from the literature, but also from many societies. So SCAI, the Society of Cardiac Angiography Intervention, has done a very good job. We had the president on 3 times to share cardiovascular best practices and share the challenges that we faced as physicians and patients and healthcare providers, that people weren't coming to the hospital with STEMI and all those kinds of issues. And so a lot of that was covered, and anybody on this call is welcome to join those going forward. But that was something that came about by our own initiative. But in addition, we had, I think, good support from industry. AdvaMed, the medical device consortium, has really done a great job helping us understand the literature for both employee health and PPE and a variety of things. So a lot of that has been available. So I'll just answer the question more generally to say that we've approached this to think about virtual training, which is sort of like what we're doing here. This is the format that we do on Fridays, which is completely virtual. And we do that. We've been doing that training for healthcare professionals, cath lab techs, and nurses in that way. We're moving to try to continue, knowing that this is going to continue, which will be something where we'll ship equipment to the hospital, like our console or models, so that it will be virtual, but they'll be able to be hands-on. So that's what we think will be a hybrid. But I will tell you one thing that we were challenged with, and I want to let you all know as hospital participants, that many hospitals forbid industry representatives to come to the hospital. And that was a real challenge for us, because we know that the hospitals in many ways did it as an act that they thought was the best interest of safety for patients and for their employees, because they thought most industry representatives were coming just for sales calls. But of course, for our purposes, many of the patients are critically ill, and we know that the physicians and nurses were asking us to come. So we had a challenge with that, and we did largely overcome that by me writing letters that they could use with CMOs of hospitals or others to say we really have a critical need to get into the hospital to support for these issues. So I would say virtual plus, and real were all parts of what we did, and are continuing to iterate that as we move forward. So I hope I answered your question, Zach, in all that, but happy to answer anything else that's needed.
You absolutely did. Thank you. So we've spent some time talking about the more administrative and technical aspects of responding to this crisis and what might be carried with us forward. But I'd like to take a moment to turn to each of you in order, but starting with Dave, about a different set of questions, which really surround the human impact and the human cost of this disease going forward and how it shapes our views. So on our call on June 4th, Dave, you mentioned that in Kansas City, you guys had to shut off the ventilation to inside the building because there was gas from protests that was coming into the building. And I think this really highlights the intersection of factors that are kind of outside of healthcare directly having an impact on our delivery of healthcare. So the pandemic's brought to light many disparities that exist and how different communities are disproportionately affected, and generally questions of equity. So I'm wondering how you think this pandemic will shape the view of the healthcare community going forward as regards equity, and also how this experience has shaped your in your personal view, if it has at all. And I'm going to throw that question to everyone that's in the panel, but starting with Dave.
So, yes, in Kansas City, we had several days of protests. Our major hospital is 2 blocks away from a large park where the protesters arrived, and as Zach said, we turned off the air intakes to our building because our nurses were detecting the scent of tear gas in the building. And fortunately, it's really tough times, and the mental status of all of us and our employees is under attack because of pandemic, because of the issues with our current social disturbance, and it's very, very unfortunate. It took the events to make it happen, but our organization, from our CEO down, from Melinda Estes, who is currently the president of the American Hospital Association, that we are a diverse organization. We will come down hard on any incidents where we recognize it's wrong. We will support those initiatives through the health system. But most importantly, a strong message to each individual in the organization to take care of yourself. We know it's a challenge. The other thing is we just recently announced a furlough, and so there's a lot of stress on people. Stress on those good people that were furloughed, stress on those that are still at the office wondering if they're going to get furloughed. And it's all these things happening. It's a triple threat right now. It's the pandemic, it's the current social issues, and it's the impact of not knowing if you're going to be furloughed tomorrow or not. And then if your friends are being furloughed, how do you support them? So there's just a lot going on right now. And from an employer, I won't even say healthcare organization, from an employer, it has to be top down, it has to be recognized, and the employees have to be supported both physically and mentally and spiritually.
So it kind of sounds like you're saying that the employer, the leadership in an organization will be more cognizant of and accountable to their employees' emotional responses going forward. Is that a fair paraphrase of what you just said?
Very good summary. Thank you, Zach.
All right, cool. John, same question to you. I'm just going in the order on my screen.
Sure. That sounds great. Yeah, no, that was really very well said, Dave. And similarly, within our organization, it's been made very clear from the top of the organization and permeates through the entire organization here nationally on our position on what's going on here specific to the social unrest. And we've actually been very supportive here in Boston. Just kind of an example of demonstration of support from our leadership, and other employees have been invited to give a sign of support to the protests that are going on here. So that's just a small example of what we did and how it's being demonstrated that, yeah, we know there's disparities. It's truly unfortunate, and the racial tension's been there for quite some time, as we know. And actually COVID has been a catalyst, we feel, to help bring that to light where it needs to be, especially where there's bad actors within our society. So we've had similar to as Dave mentioned as well. It's almost been a PTSD effect to our staff at times, and we've offered up any type of behavioral support, psychiatry. We've had staff that have actually had family members that have contracted and died. We've obviously seen patients and cared for them directly in mass, unlike anything that anyone has ever seen here within our generation or the past couple generations. And even staff themselves unfortunately have contracted and died. So it's been very challenging. multi-layer, and but it's been critical that we have the support of each other, and that's what we've seen. So together, I mean, it's a bit cliche, but it really does demonstrate what needs to be done here for us to be able to survive and then thrive coming out of this together. That we all, probably the best term, and maybe it's maybe kind of from a principle-based standpoint, and at least it drives me anyway personally, it's just to love your neighbor. It's that simple. I mean, just treat them like you want to. Everybody, treat everyone, anyone who's near you, treat our neighbor, as ourselves. So.
Hopefully that is the principle that's guiding everybody here. But yeah, Dave, go ahead.
But one other thing I might add is we've taken advantage of social media to share messages. So Dr. Estes has the message she gave to all of her team out on YouTube. I'll send you a link, Zach, after we're done here. And then we're sharing success stories through social media. A pregnant woman came in with COVID, was induced, and then placed in a coma for 38 days. And as her new baby and the baby's dad left the building, there were crowds encouraging them, clapping as they went out, and I mean, it was just a great story. And we're making sure that we share those success stories to enlighten and encourage in a time of really challenging situations.
Yeah, excellent.
That's great. I really do think that, I mean, this is a personal belief. I'm not going to take up much time here, but I do think that solidarity has an infectious quality to it, which is certainly not a solution to the other infection that we're facing, but I think it could be part of a solution, certainly. Russ, I'll turn to you now. The same kind of question. How has this experience changed the way that you see or experience equity and disparity in healthcare? And also, is Loma Linda doing anything going forward to directly address these concerns?
Well, being that our guiding principle is to make man whole. This is both the response to the pandemic and the response to the social justice issues that are going on up there have been extremely galvanizing for staff, the spiritual leadership that we receive here within the institution. And we've made it a point to not only recognize the stress of the pandemic and make sure that people have the resources that they need there through counseling, through support groups, through critical stress debriefing incidents done virtually, but we've also taken the time to recognize the need for people to express themselves. And we've had silence demonstrations in recognition of what happened in Minneapolis. We've had team and our clinical leadership team, or in our executive leadership through social media, have shared various messages of we're here for you, we're open. Even if it's just a talk, we'll figure out a way to make it work. There's a large area on campus that is a very large park, and you can find our spiritual guidance team in there daily around lunchtime for anybody who needs to talk. And of course, they do it in a socially distant manner, but it's been very well received, and it's been very galvanizing for everybody to look around to see that we are brothers and sisters and whatever we face, and it's a community, really.
That's awesome. Monica, same question for you at the University of Florida. Have you had any experience with this kind of like equity, the community building force, and noticing any disparities in the delivery of healthcare or anything like that?
No, I haven't noticed any disparities in the delivering of healthcare. We are, well, I don't know the right term for it, but we have the city contract for patients who are low income. So we see a very diverse group of patients here, and I don't think that we have ever had any issues here with how we treat our patients. And I don't really see that in our community here. Our CEO has done an excellent job of really promoting and enforcing and encouraging the diversity here in our organization, and making sure that we're quite diverse and that we have celebrations for diversity. Another thing I wanted to say that he does that's been great is he does a video 2 or 3 times a week, and it's called A Few Minutes with Us. It used to be called A Few Minutes with Russ because our former CEO was named Russ, and so he just changed it slightly to A Few Minutes with Us. And on that video that he does, which everyone here in the organization can see, is he updates everyone on how many patients we have that are COVID positive, what's going on in the hospital, but also what's going on in the community. We last night had some pretty bad protest riots downtown, and we are located right downtown. So we all get very informed of what's going on and how we can help and what we can do and how we can support each other. So I think having leadership that is very supportive of pulling us all together as a team and a group, it starts at the top, and having him do that and everyone being on board with that. I think that we really haven't seen any issues. Now we're very concerned again about the Republican convention coming to town. We are not that far as a hospital from the site of where the convention will take place, and we know that there's going to be a lot of protesters during that time. So we're trying to figure out the best way to, as a team, as an organization, get through that. We've had a lot of employees who don't want to work those few days that the convention's here. But as a whole, I think that we've handled things well and that we have really pulled together well as a team.
All right, thank you. And I think you're right that cultural, I guess if I was going to make it like a standard, I would say cultural competency, but I agree with you that it's definitely demonstrated in leadership and then has a way of kind of flowing through the rest of the organization. So that's very lucky, and it's good that you have a leader that's so aware of these things and works to make the rest of the organization aware of them as well. Since we only have 5 minutes left, I'm going to jump to the last question I have, and it is a very quick question, so I'll ask this to everyone. But if you could describe your aspiration and then also your anticipation for a post-COVID-19 world in 1 or 2 words. So I think that aspiration and anticipation should be different because we should be aspiring beyond what we might realistically expect. But if you could just, in 1 or 2 words, what you think we should aspire for post-COVID-19 and then what you anticipate for post-COVID-19. And since we are, since I didn't get to Dr. Bilazarian on the last one, I will start with you, Dr. Bilazarian, with this question.
So on our weekly call that I mentioned we frequently deal with anticipation, because I think we all want to know what to prepare for organizationally, individually, even personally. When will my gym open so I can go work out again? So I think we're all dealing with that. I don't have any insights. I'll just share that the New York Times did a survey of 500 infectious disease specialists and epidemiologists, and they were all over the place about what to anticipate, and they're the alleged experts. So I can't answer the anticipation, but we all are eager to know because the uncertainty, I think, creates a certain amount of anxiety. What I hope will come from it, my aspiration is that a lot of positives have come out of it, like we just discussed, like virtual training and other kinds of ways to be more efficient. I think our hard skills that have come out of this that I think we're all getting better at. None of us did this routinely, I think, and we're doing it more routinely, and we're getting better at it, and the technology is getting better, and I think it will become more effective. I'll just share a personal anecdote. My daughter is a nurse in a New York City emergency room, and she shared with me, because I'm no longer a clinician on the front line, so there's a little bit of guilt about that, and I wasn't on the front lines about all this, but she shares with me something that I've heard from others as well, that there was really a breaking down of hierarchy and other kinds of issues, sort of a wartime mentality that everyone was looking, because she, as a young nurse, knew as much about COVID as the senior ER attending. So there was a lot of this sort of camaraderie and collegiality and sharing that broke down hierarchies that was really valuable. And I hope that my aspiration is that will continue, because we can all learn from one another regardless of our station or years in practice. So that's how I'd answer your question, Zach.
All right. That would be great to see this is going to be a not totally delicate way to put it, but a shedding of ego is the way that I would describe it, like throughout the medical hierarchy. Russ, I'll turn to you next. What you anticipate and what you aspire for post-COVID.
I anticipate a greater accessibility for everybody, be it virtual or in person. And what I aspire to is to really continue to be as flexible as we have been in healthcare, because the COVID crisis has created a unique opportunity for us to fast track technologies that we weren't using, to fast track training, to look outside of the traditional box as to roles or who is doing what. And I think the benefit of that will be far reaching and will continue to benefit healthcare, hospitals, nursing homes, and the community as a whole.
All right, thank you. Dave, same question. Aspiration, anticipation.
Yeah, so I'll start with anticipation. So anticipation is the if and when a vaccine for COVID-19 to kind of bring life a little bit back to normal. But a bigger anticipation is, I mean, we have known of infectious diseases and pandemics for some time, and we're totally unprepared. And after COVID-19, is there a COVID-21 or a COVID-23? And have we learned enough to be more prepared next time? Aspiration is just the goodness in people and people stepping forward. I mean, so many colleagues, so many friends have just, gone above and beyond my expectations of them, my personal knowledge of their abilities, their commitment, their willingness to step forward and help. So I hope that continues.
I hope so too. Georgianne Bruschi, who was supposed to be on this call, she had mentioned in conversations previously that in times of great stress and times of crisis, you see two types of people crop up, and she referred to them as the heroes and the profiteers. And I think that is an absolutely brilliant way to look at our responses to a pandemic. Hopefully there are far more of the hero category than the profiteers. John, anticipation and aspiration.
Sure, and it's very similar to what Dave had just mentioned here. Obviously, on the short term, to see a vaccine, and as we know, we're in the phase 3 here with some of the trials beginning next month with Moderna in particular, and then there's quite a few others, AstraZeneca and J&J and the like. And with that anticipation, some of the things we've done organizationally is actually beefed up our entire research, education, and teaching. So we're investing quite a bit of funds to help with that, to help as some prevention, similar to what David mentioned, and also to help with some of the disparities that we talked about earlier. So I'd say then from a aspiration, I just put it in 3 quick words. I'd say inclusive, collaborative, innovation.
Wow, great words.
All right, thank you. Great. Monica, last comment of the panel, if you please. What you anticipate and what you think we should aspire.
What I anticipate is similar to what Russ said. I think that there will be greater access to healthcare going forward. I think that we've all become very creative in ways of making sure that patients get the healthcare that they need. I think the workforce is going to look a little different. I think now that we have had so many people working from home, that that will continue. We always talk about space here. We're always running out of space in our hospital, our organization. And now as we look to taking some of the workforce and having them work from home, that may open up some of our space needs. So I think that we'll continue to be very creative in how we utilize our workforce. What I hope happens is I hope that everyone will continue to realize the importance of what slowing down can do for you. I think that with everyone having to slow down some and not be able to, I know that my life changed. I was, the weekends were full of sports and this and that and the other, very rarely home. And now it's good to have dinner with my family and everybody's sitting at the table and paying attention and talking. And I see that happening with our employees here in the hospital, our staff and our physicians. And I think having that slowing down mentality has made people a lot more compassionate and understanding in these stressful times. So I hope going forward that once we can, and there's a vaccine, that we all don't just rush back into our very busy lives.
All right. With that, go ahead, John. Oh, I hear myself in an echo somewhere. I'm sorry about that. With that, I'm gonna end the panel discussion. Thank you all so much for joining us. And oftentimes when you ask a question about aspiration or what the future looks like, you do get a sort of idealistic or over-romanticized picture. Appreciate you guys giving us actionable, concrete answers to these questions throughout the day, but especially that last one, because we need actionable terms right now. Thank you all so much, and have a great day.
Great, thank you. Thank you, everyone.
Thank you.
Take care.
Have a great day.